And I know that that's happening. So we are recording now. I'm grateful for everybody's return, and we can crack on. And I'll just let Liam in there. He's in, yeah, that's fine. Okay, good stuff. So resuming our board of directors, you know what I'm like, which can cause problems sometimes in terms of timekeeping, I know, but I do want to encourage contribution. I think the quality of the contributions has been superb to date. So let's go to finance and performance issues. Obviously, we've just talked about the health inequalities analysis work, the great stuff we're doing there. And I'll turn to Julie. Julie, obviously, we're helped by the chair's reports. So we'll take those as read, but may I ask whether there's anything you want to emphasise to director colleagues about them, please?
Yes, I just want to I want to take the July report as read. It's July, we're meeting again next week in September. The world has moved on, so the report take as read. I do just want to give Chris a couple of minutes to talk about the financial position as at month 5. So the report will be going into more detail at F&P next week. Chris and I had a conversation about yesterday. So if it's all right, Max, I'm going to hand over to Chris. The 3A report talks about a red risk. That red risk is materialising. So can I pass over to Chris?
Of course, yes, and we can, of course, use questions and comments as well. So, Chris, good morning, and just good morning. I can just get away with that now for 1 more minute. So, anyway, the time's yours, Chris. Thank you for briefing us.
Right, thanks, Max. As Julie said, the risks that we were flagging up earlier in the year, we're now at month 5, and we're in a more reasonable position to understand how the year is panning out. And as Julie says, the risks that we've been flagging up are starting to crystallise. So I'll talk through briefly, I'm conscious of time, I'll talk through briefly the position that we've reported for month 5 and the number of scenarios for the forecast for 23-24, and particularly the impact of that when we're looking forward to 24-25, so not restricting our horizon to this current financial year. Yeah. And the financial outlook is a bit concerning now. So colleagues will have noted from the report that we submitted for month 5 that we're now reporting a year-to-date deficit of 2.2 million, which is a departure from how we've been reporting up to month 4. Previously, we've been offsetting the costs of the industrial action with non-recurrent flexibility to report a break-even position. But the issue now is that when we've looked at our more detailed forecast for the rest of the year, we are going to use whatever non-recurrent flexibility we have, or need whatever non-recurrent flexibility we have to offset shortfalls against waste reduction plans and other pressures that were anticipated in the plan. So, and to be consistent with other WIAC trusts as well, we're now reporting a deficit equivalent to the costs of the industrial action, which is 2.2 million at the end of month 5. So that's that position. We're now consistent with WIAC, but we're in a deficit year-to-date position. Now, there's a number of different forecasts to consider. So the formal forecast that we've submitted to NHS England remains break-even, and that's consistent with the agreement with the ICS. We are flagging all of the risks related to waste reduction programme delivery and particularly the industrial action costs in our monthly returns to NHS England, but the formal forecast is remaining break-even. We do believe it's too early in the financial year to start forecasting off plan. A lot of this is still within our gift to address in terms of increased waste reduction delivery, financial controls, etc. So it wouldn't be sensible at this stage to forecast going off plan. But I think there's an important thing for us to understand internally and for the board to be aware of, that there are significant unmitigated risks at the moment to delivering that forecast. So that's the formal forecast is break even. Now, internally, for our own understanding, there's 2 scenarios really that we're looking at, and this is before any mitigations. There's a forecast which assumes that all of the costs that we've incurred related to industrial action are somehow mitigated by additional funding from the centre. Yeah. And then there is a forecast where there is no mitigation. So in the more optimistic forecast, where we do get some support, we're projecting at the moment, and this is based on figures provided by the CSUs around recruitment trajectories into investments and forecasts for waste reduction delivery in the second half of the year. We're forecasting the underlying deficit to be £19.1 million for the year. Now, we'd anticipated deploying 8 million of flexibilities to offset that, with the gap being bridged by waste reduction. We're now looking at a shortfall on waste reduction, which means we're going to have to we have identified another 8 million of flexibilities to deploy, which would get us to a £3.6 million deficit. At the moment, we don't have any further mitigation against that. I'll talk about what we're trying to do to address it. But we're projecting at the moment that we'll run into a deficit position at some point in Q4, and the latest estimate is that at the end of the year that will be £3.6 million. Now, that's driven largely by the run rate in months 1 to 5, excluding industrial action. We've got a £900,000 on average deficit position that we are offsetting with flexibilities. That's projected to deteriorate in the second half of the year due to recruitment into planned investments, successful international nurse recruitment, winter pressures, etc. These things where our costs will increase as the year progresses, and that's why we're projecting being unable to mitigate it with non-recurrent issues. If we don't get any support from the centre around industrial action, that deficit will be in excess of 9 million, and that's not something we're anticipating being able to bridge. So I think it's probably worth flagging that if there is no central support for industrial action costs, we're likely to be in a deficit position. The 3.6, if we do get support, we're putting all our efforts into bridging that, and we're hoping that something can be done to address that. I think it's very important to emphasise that we're not alone in this position. So the rest of the providers in our ICS are also in this situation where they're projecting break even at present, but they've got unmitigated risks to that forecast. Important to understand what this means for next financial year, where we hope the industrial action won't be an issue. So we're projecting that in the final quarter of the year, our underlying deficit, if we don't make improvements, will be £2 million a month. So that'll be our run rate deficit will be £2 million a month. If we carry that forward into next financial year, that'll be a brought forward deficit of £24 million. The usual issues around national tariff efficiencies and inflationary pressures and things will probably push that towards a £40 million deficit, which would be unmanageable for us really in one financial year. So the outlook is very challenging and very concerning. This really highlights the importance of us identifying recurrent improvements to our run rate through the waste reduction programme. Following on from Fahim's point, it's worth making this point. Fahim made the point in the earlier conversation about industrial action, about the impact on our teams, our budget holders, our clinical leads, their ability to do other things, and the disruption to their ability to construct recurrent sustainable waste reduction plans where we need that clinical input is severely impaired. Now that's not going to be seen as an excuse by NHSE, but it's context for us to understand that's important really. So that's the outlook for 24-25. Appreciate we're running out of time. In terms of mitigations that we're putting in, once we've started to understand this forecast, Matthew wrote out to the CSUs in August highlighting this position and asking for improved forecasts for waste reduction in the second half of the year. We've had some responses from that. They've not factored into the forecast I've just talked through. So we've got £1 million forecast improvement for the current year, which will bridge that 3.6 down to 2.6, and a £2.5 million recurrent improvement for next year. So there is progress being made. Obviously, those numbers are small in the context of the numbers we're talking about, particularly for next year. But we're confident we'll get some more positive responses back from the CSUs. But the work needs to continue. We're putting in place increased governance and increased meetings to focus on this, particularly with CSU engagement. And in line with NHSE's expectation, who've issued a number of financial controls they expect organisations to put in place, we are exploring tightening controls on recruitment and expenditure and things like that to try and manage that run rate down. So in summary, it's a risky outlook for 23-24 with a potential £3.6 million deficit if we get funding for the industrial action costs. If we don't, it might be a £9 million deficit. We're doing what we can through the CSU engagement to bring that down in financial controls, and we're hopeful, non-recurrently at least, we'll probably try to bridge that gap and deliver the plan this year. The more concerning issue is the reliance on non-recurrent measures and what that means for 24-25, where we potentially risk having an unmanageable financial challenge if we don't make improvements in the final half of this year. And final point, just to really emphasise, we're not alone in that in Bradford. That is a common picture in all of our partners in the ICS.
Chris, thank you so much. That's a very clear briefing and great use of lay language, if I may say so. So I completely understood everything you were saying, which in a finance briefing can sometimes be a challenge for those of us not trained in that. So well done. I think we're clear. And we accept, do we not, directors, a collective responsibility in managing this with waste reduction programmes, etc., and efficiencies. So thank you, Chris. Really good briefing. Julie, was there anything else you wished to report on? And then I'll open up for questions and comments. But let's just give you the chance to conclude on anything else F&P.
So just quickly, that paper will come and be discussed in more detail with some more detailing at F&P next week. I think we're in an unusual sequence where we've had board in advance of F&P. So usually we've had the F&P paper and then we see it. So we will be discussing it in detail. We will be looking at it, but we just thought it was important that board understood those messages that are just coming to light.
And they were very clearly articulated. So thank you. Thanks, Julie. Thank you, Chris. Mel, would you like to come in, please?
Thank you very much, Chair, and thank you, Chris, because that was a great explanation. I just want to emphasise the point Fahim's made, Chris has made. Trying to carve out some protected time for our clinical teams, our CSU triumvirates, to focus on practical ways they can help reduce expenditure is really difficult. Saj might reference, we took the CSUs out when he comes on to talk about activity levels. We took the CSUs out to the Life Centre for an afternoon. To really kind of give them the space to focus in and amongst all the industrial action. Matthew would quite like to do that. I know that what we want to create is a series of opportunities to have some really focused conversations about this stuff. I know Karen and Ray are thinking similarly about some of the challenges of the three-legged stool, if you like: people, quality and sustainability. And how we can make sure that in resolving one issue, we don't destabilise the third leg of the stool, that is, we can save some money, but it has a quality impact. We can have quality, but it has a cost impact. So that's the philosophy that we're taking forward, and an acknowledgement we have to, really focus in on this.
Thank you, Mel. And Ray, would you like to come in, please?
Yeah, just very briefly, because I'm in danger of more of the same, but I said before about the phenomenal job that all the operational teams are doing, and I also said that we're in a period of strike action now, and immediately after we start planning for the next strike action at the beginning of October, doing the business as usual and beyond the business as usual, and finding waste reduction opportunities is really challenging amongst just keeping our heads above water with industrial action, and I think it's just really important to understand the pressure that the teams are facing at the moment, it's a difficult period.
Yes, yeah, as Mel articulated as well. Thank you, Ray. Yeah, and Paul, please do come in.
Yeah, thanks, Max. It was just to make the point too that the other thing that's incredibly time consuming, but also potentially fruitful in so many ways, as we've discussed across this morning, is partnership working. So it's not only those activities within the organisation where we might be seeing or looking to see the efficiency opportunity in front of you, it's also those ones that take a longer time to identify, a longer time to develop the relationships and the trust and the confidence to address comprehensively. They're also going to necessarily be adversely impacted by the fact that delivering the here and now and safe services in the context of industrial action is the most pressing concern for everyone.
Thank you, Paul. Yes, good point, actually. Yes, of course, about our collective responsibilities beyond the trust walls, if you like. Yeah, thank you. Okay, Chris, terrific briefing. You told us it like it is, and that's what we need to know here. And it was very well put. Thank you. Very clear. Julie, thank you for your summary there. That's really helpful. And shall we move to item 10 then, please, which of course is within the finance and performance issues, which is about protecting and expanding elective capacity. We're being asked to note the progress made to allow completion and submission of the self-assessment signed off by myself and Mel at the end of this month. Saj, the paper is obviously tabled with us and we've been able to read it, but of course, is there anything you just want to emphasise with fellow directors, please?
Yeah, excuse me. I think this leads on actually quite nicely from the previous discussion we're having in terms of the expectations. So on the one hand, we've got the pressure day-to-day operational response to strike action, the cost of the strike action, but actually very clearly the expectation from NHS England, quite rightly actually, in terms of the long wait patients, and that I don't object to that part of it, is that we protect and expand our elective capacity in order to ensure that we deliver the aspirations that are put out as part of the planning guidance, and having no greater than 65-week waits by the end of March. There's 3 key areas within that letter that came out from NHSE that they've asked us to focus upon and for boards to gain assurance on. And that's been around validation, first appointments and outpatient follow-ups. We've added quite a number of appendices into this paper, which gives you the background. So I don't intend on running through the detail of that, other than saying that we have been, and with the support of board, ETM, and through finance and performance, we have been undertaking quite a lot of validation work, and this fits with our view on getting data quality right, because this is about making sure that only those patients who are on the waiting list are absolutely the ones that are waiting for treatment. We understand what they're there for, and if there are duplicate pathways, etc., that we manage those through. So we've had lots of work done around that area. We're also introduced digital contact with patients when they reach a specific milestone of 12, 26 and 52 weeks. And we do that on a weekly basis. We're technically validating, making sure whether the patients are genuinely waiting for appointments or not. And we're updating our policy, access policies, to be in line with WIAT access policies, so that we're consistent in our approach. Not only are we focusing on just RTT, but we're also looking at the non-RTT pathways as well. And what we've seen is a reducing number of patients waiting beyond their C/by day. More work to do on that, but it's definitely been reducing. Where the board can get visibility on this sort of work is through F&P, which obviously is a committee of the board, through the reports that we share in terms of the visual wall, and you can see the number of patients that were above 52 weeks, that were above 104 weeks, and how those have been coming down. And also in terms of the number of completed pathway and the amount of activity that we're running. So the board hopefully is able to refer to certain documents which allow you to see the impact we're having. In terms of 65-week cohort, so these are the patients who would breach 65 weeks by the end of March. So we're working at a much lower level than that. We need to get anybody who's at 30 weeks plus currently plans in play in order to avoid those individuals becoming 65 weeks. We've added some level of detail in there just to give you an overview of where we're up to. So as at the 10th of September, we had 780 patients on our waiting list that fit within this target cohort. It's pleasing to know that 694 of those patients have a first appointment booked. And of the 67 patients that are waiting, we know which specialty they relate to. So it's community paediatric patients, and we're exploring the opportunities around bringing those waits forward. The board have previously signed off our outsourcing plan, and we've been relying on and using independent sector partners to help us maximize internal delivery, and that's why we're in as good a position as we are, despite the challenges we've faced. And in outpatient follow-up perspective, a huge amount of work going on around trying to, and this is through Actors One and the Access work stream, around making sure that there are alternatives to referrals. So things like e-consult, advice and guidance. We've got a phenomenal amount of work undertaken on assist pathways, where we've got over 100 pathways on assist. So this allows the GPs to look at specific pathways, identify what they should do with the patient before they even make a referral. So we've had great engagement across place from hospital consultants, but also from primary care in terms of those pathways as a means to trying to reduce the demand coming through. We've got more work to do, without a shadow of a doubt, and this is the work we were picking up around DNA rates, around nudge theory, about text messaging, calling the patients before their appointments, and moving as much as we possibly can to digital reviews in order to free up more capacity. So all in all, a significant amount of progress made in this area, more work to do, and we continue with that. I hope there's lots of opportunity for board to seek assurance, whether that be through, as I say, the weekly Wiswall that comes through, or the updates that we provide to F&P committee to allow us to sign off this submission that needs to go through by the 30th of September.
Thank you very much, Saj. That's a really useful briefing. Colleagues, are we content to note progress there? I think we're well briefed. The information provided is significant. Yeah, Saj, thank you very much indeed. That's noted, and we note the progress being made. And thank you for the work you're doing there. Thank you, everybody. We'll move on then, if that's okay. We'll move on to the quality and patient safety issues, given that we asked Sarah to rejoin us at 12:15. Sarah, we'll go straight to your item at item 12. We're assisted, of course, by the detailed papers that are provided, and I can see that there are a number of recommendations in the main cover paper. But let's turn to you, or through Karen first, perhaps, just to check whether there's anything you'd wish to emphasise with us. But we have got the papers, and I think we can hopefully be reasonably succinct, with the exception of those matters you want to particularly direct us towards. Karen, in introduction, is there anything you'd wish to say?
Thanks, Max. So a couple of things. So first of all, everything comes full circle. So we're talking about Ask for Better and health inequalities earlier. And Carly's at the National Maternity Safety Conference, where Donna Rockenden, she just tweeted, Donna Rockenden was presenting on her findings of looking at maternity services, and actually had pictures of our service up and was praising us for the work that we've done around the food banks. So I think that's a real bonus for us, BCHFT, because you may or may not remember a few months ago, we actually had a visit with Donna. She came to look around the trust, and obviously took some good stuff away with her. So thank you, and thank you to the team for that. I think it's only right and proper today that we probably just think a little bit more about neonatal services, considering what we've seen in the press in relation to Lucy Letby. And that you will know, board, that we've been including our neonatal outcomes in our board reports for over a year now, I think, maybe 2 years even. So it is something we receive on a monthly basis or bi-monthly at board, but I think it's just worth pausing and asking Sarah to comment on that. And perhaps we should consider at board inviting one of the neonatal consultants or head of nursing for neonatal to come to a future board to complement Sarah in the delivery of those reports, and to ask any more in-depth questions. But I'll hand over to Sarah at this point to take you through the highlights of the last couple of months' reports. Thanks.
Thank you, Karen.
Thanks very much, and thank you for stealing my thunder, Karen. I was about to mention Donna myself, but you got in there first. So I'll give you that one. So we can move straight on to the next slide, please. So this month we're talking about the updates that were provided to Quality and Patient Safety Academy related to June and July activity, which feels like ages ago now, but really it was only just around the corner. And also just a quick update on the Maternity Incentive Scheme Year 5 position. So June, July highlights that were presented to QPSA as a delegated authority trust board. They received and approved the papers, appendices and the recommendations. And as you're very aware, there are lots of appendices and various bits and pieces that go to Academy for their approval and support. The papers included details of harms, including our stillbirths, neonatal deaths and hypoxic ischemic encephalopathy cases, and any completed investigation reports were also included for learning, and I think you've also got access to those as a closed trust board for information. In July, we also did a brief update to ETM to provide a presentation regarding the predicted position of the Maternity Incentive Scheme Year 5, which hasn't been a full year. It's quite unusual this time. We haven't got a full year to actually achieve it, and it's got to be said that it does come with quite a lot of challenges this time round. If we could just move on to the next slide, please. So the discussion points that came through QPSA were around the number of harms that were discussed. We also informed QPSA in June that we were going to be having a deep dive of the HIE, so that's the hypoxic ischemic encephalopathy cases that had occurred during 2022-23, because we'd identified ourselves as a possible outlier. Now, unfortunately, due to industrial action and just pressures over the summer holiday months, this round table still hasn't been done, but it is booked for the next week. So what we were proposing to Academy and then to board subsequently was that we will bring the findings of the round table and any recommendations for further learning, and it's as much as anything for assurance that we're actually doing the right things and looking at the right things. We also wonder, as is quite usual for Bradford Maternity, that are we being more honest and transparent than some of our colleagues? Sometimes I think we do provide quite a lot of information, so we're actually wondering whether some of the recording of the HIEs includes the cases where a baby ended up with a normal brain scan, which some organisations may not be including in their total numbers. We also looked at completed reports, as I've said, and I gave QPSA updates on the progress on actions. We shared the perinatal mortality review tool quarterly report that's required for the incentive scheme in July. And we also shared the ATTAIN and the which is the avoiding term admissions into neonatal unit, and the transitional care unit quarterly reports, which again is another safety action for the incentive scheme, and that went to August Academy. We remain very low on our, in a good way, on our percentages for ATTAIN, but we have actually identified that even though we're low in number, we can absolutely strengthen our MDT approach to reviewing the cases that do come through. So that is planned for moving forwards. The June and July maternity training compliance was presented and discussed at both July and August, and we're now presenting on that on a monthly basis rather than quarterly. So that's just a small update. The July Academy were also informed that we had an emerging concern about the core competency framework training requirements and the significant increase required for midwives, particularly to meet compliance. And that was one of the reasons why we then took an update paper on the incentive scheme, of which this is part, to ETM. And I'll give you a brief update following this. So if we could just move on to the next slide, please. That is around the MIS Year 5 position. So Year 5 of the scheme. So for 4 successful years, we've managed to achieve compliance with all 10 safety actions. The 10 safety actions remain unchanged, although there are some subtle alterations to the action descriptors. There's some additional board level evidence that's required for some of the actions, which I propose will continue to go through QPSA in the first instance, and then I'll draw them out to board as I'm doing today. This is the first incentive scheme submission since the publication of Saving Babies' Lives version 3, and that is one of our challenges. At this moment, we're uncertain if we will meet standard, particularly if there's further increase to scan recommendations. That benchmarking exercise to give us a little bit more information as to how we think we're doing against that is well underway now, and we've actually got a peer review with the local maternity and neonatal service system, next week, to actually support us with going through our evidence, and that's now been uploaded to a national platform as well. I do think actually, since I wrote this presentation, that we possibly feel we are in a slightly better position than we first anticipated with this particular domain, so that would be reassuring if we do think we can achieve it. As I mentioned, the core competency framework training requirements have significantly increased the number of mandatory training hours that's required by every midwife. And unfortunately, this is in regards to the head count, not the whole-time equivalent. So whether you work 16 hours as a midwife or whether you work full-time, the training requirements to make sure that you are safe to practice and to give us that level of assurance remain the same, which is a significant challenge with the backdrop of ongoing staffing challenges. There's a trajectory to meet 90% anaesthetic and obstetric compliance within the prompt, which is our emergency training. At the moment, that's still quite fragile and is sort of sitting on a bit of a knife edge if the industrial action persists. We are looking at our trajectory is achievable, but it is very dependent on things like no further industrial action, and there is a potential that we may need to stand some clinical activity down in order to achieve this as well, and that would be antenatal clinics, obviously looking at minimising any disruption to our service users and to our safety, but it's quite a significant challenge. The ICB funding of the Maternity and Neonatal Voices Partnership is also at risk at the moment of being insufficient to meet the maternity incentive scheme and the 3-year plan requirements for both Bradford and Airedale. The funding arrangements have been amended with some input from Mel, which was very much appreciated, but unfortunately the demands that are now being put on our MMVP leads is far greater than it ever has been before, due to recommendations from Ockenden, which have then gone into and from Kirkup, which have then gone into the 3-year plan, in addition to the incentive scheme, which continues to grow year by year. Because we had a bit of a hiatus with the MMVP, we had a step down of chairs, and now we've got new leads. They are still very much finding the feet, and although the main meetings have been resumed, we're going to really scrabble around a little bit to be able to evidence, provide some robust evidence of co-production and compliance for that metric, which is a little bit out of our control, but we're working really closely with the new leads to hopefully achieve as much as we can there. So the next slide, please. So the next slide is very much just a visual. It's got the 10 safety recommendations and where we think we are with them. So as you can see there are 7 domains where we don't think we'll have any challenges in actually achieving those. Again, I think I've probably been a bit of a harbinger of doom here, and I've gone as I've gone for the worst case scenario, which I'm hoping is probably slightly better than I'm portraying it at the moment. But the Saving Babies' Lives Care Bundle at the minute we've put as red. I suspect that may turn to amber following our meeting next week, and our MMVP elements, as I said, is also amber at the moment. And interestingly, I think out of the 3 of them, that may be the one that goes red and the other 3 become amber. But we'll keep you updated on progress there. And then the professional training side of it, which is a challenge, but there is a robust plan in place, but it will be very close to the wire for us to achieve. So the next slide, please. So the conclusion from the review of the position at the moment is, as I said, we've got a high level of confidence for 7 of the actions, a moderate to high risk for 1, and high risk for 2. So the next slide there, please. So the risk to us if we're not compliant. Now, obviously, there's quite a significant financial risk there. The trust won't receive the total premium, and we know that we were fortunate this year that we received our premium, plus we also received a share of the unspent premiums from other organisations that hadn't achieved. So that is a risk for us. Reputationally, the MIS does exist to provide assurance and evidence of safe services. So declaring non-compliance, although absolutely the right thing to do if we don't feel we're achieving it, it may attract some external scrutiny if we are unable to demonstrate mitigation and robust action plans for the standards that aren't achieved. I would say that we're not alone in this. This is speaking to peers. There are many organisations that I don't think will be declaring full compliance. And actually, when you look on the website for last year and who achieved it, there were significantly fewer organisations that declared full compliance last year as well. So I think it is definitely starting to take its toll. Trust board sign off for any of our action plans that will be required to support our self-declaration will need to come to January board. So that was just a little bit of a reminder that if we could kindly ask for that to be put on the agenda for January, I'd be very grateful. And then the final slide, that's me done then. So the request for September board is firstly to approve that you're assured that QPSA have reviewed on your behalf and discussed the contents of the June and July papers, and as a committee of the board with delegated authority appendices, then that you can see those as appendices 1 and 2. To note that a multidisciplinary team review of the HIE cases will be taking place in September, and we're hoping to be able to provide those findings to October QPSA, November at the latest now. Trust board are asked to approve that you're assured that Academy have reviewed the June perinatal mortality review tool quarterly report, which included learning and is required as an element of Safety Action 1 of the incentive scheme. And very similar for the next action, that QPSA have done the same for the July Attain and TCU quarterly report, including learning, again required as an element of the incentive scheme. Closed board are then asked to note the appendices 3 and 4, which describe the stillbirths and neonatal deaths and harm that occurred in June and July, and to note both new and ongoing investigations. And alongside those, there are 3 completed HSIB or internal investigation reports, including the investigation recommendations for your awareness. Trust board again to note the concerns regarding meeting the core competency framework training that was reported to June QPSA and then to ETM. And then finally to note the Appendix 5, which is the maternity incentive scheme update position that has again been to ETM first, and the current prediction that we may not be in a position to declare full compliance at the moment in February. And that's me done.
Thank you. Thanks very much, Sarah. We certainly don't want to rush you. We're conscious how much we have to get through, but we're helped by the detailed papers. Thank you for the preparation of those, Sarah, and indeed your concise brief. So thank you. Colleagues, are we content with the information we've received? Are we comfortable with the 8 recommendations that we're being asked as a board to note? And have you had the chance to query anything? If there's anything you want to do outside of the meeting, of course, but if anything needs to be raised here, let's do it. But otherwise, we're okay, aren't we? Yeah, okay, that's great. Thank you, everybody. That's absolutely fine. What we'll do is, well, thanks, Sarah and Karen, for the. It's great to the director of Midwifery here, of course. So pleased to note that. Shall I bring you in, Karen?
Yes, thanks, and thanks, Mel. I was just going to reinforce. So I just think with the Letley case that's been in the news since we've met as a board, it's just worth reinforcing the level of detail that has gone on in the papers around not just maternity services and intrauterine deaths, but neonatal deaths as well, and HIEs, which is where babies are starved of oxygen potentially at birth that can cause ongoing disabilities. So all of these things have been reported robustly on a monthly basis. I think the next thing to draw out, and it's picking up on what Sarah was saying, we recognise that we were maybe an outlier for HIEs a few months ago and agreed to do the tabletop. And Sarah was saying about, we don't know if we over-report and some people under-report. I think throughout my career, I hear that sort of said about lots of different things, incident reporting or whatever it may be. And I think the important thing to remember is benchmarking is important. There will sometimes be flaws with that, and it's an indicator, and it should be a bit of an alarm bell. But what is more important, and how this was picked up, is knowing and looking at our data, our own data, on a monthly basis is really important. So, for example, if your stillbirth rate is 1 a month and the national average is 4 a month, and you suddenly have 3 a month, does that mean that you're below national average so you don't look at it? Well, you do, because you've had a step change in your own data and your own performance. So I think it's really important that, there's lots of different ways that we analyse the data and the trends of that. And that allows the team to be really proactive in picking up on where concerns may be.
Thanks very much, Karen. That's noted with thanks. Okay. Sarah, thank you. It's good to have Director Midwifery here present with the board, so very much appreciated. Thanks, everybody. What I'm going to do now is I'm going to skip to item 16 because we've got Helen and Shaq who have joined us, and as a courtesy to them, rather than keep them waiting about, we'll get into that. Thank you, Sarah. See you later. Yeah. And I will come back, of course, to Sugra just to check whether there's anything generally in quality and patient safety she would wish to bring to our attention. But let's pay a courtesy to the guests we have at our board meeting. Lovely to see you both, Shaq and Helen, who, of course, we all work closely with in partnership and who I've known for some time. About Shipley Hospital, and we've been asked to note the proposed next steps and reflect on the feedback we've had from people. But it's an opportunity for a brief update as to what's happening with that old building, which is important to local people. I'm a Shipley resident, so I do know that. Not an easy decision for us to take. However, we need to know why that's been made as the board of directors for the biggest hospital trust in the area. So shall I turn to Helen and Guess in the first place, although it could be Shaq. So Helen and Shaq, a warm welcome to you both. Thank you very much for joining us in person. And shall I turn to you, Helen, and ask you to introduce the item?
Thanks, Max, and thanks for adjusting the agenda for us. So for those who have not met, I'm Helen Farmer. I'm the Programme Director for Access to Care, and I'm with Shaq Rafiq, who is the Associate Director for Communications and Involvement, and we both work for the Bradford District and Craven Health and Care Partnership. So apologies to those who have heard this previously at the partnership board, but it's important that we make sure we go through the right and due process and governance route for taking this decision. So we have been to the board before, probably about this time last year, actually, with an update on what we were doing with regards to Shipley. So the proposal is to move outpatient physiotherapy and community physiotherapy services from Shipley Hospital. We have been following a NHS England assurance process, which is very strict in terms of the levels that you need to go through. We've been through stage 1 and stage 2. In terms of the governance they anticipate that we pursue and what we do from that. And most importantly, out of that, the period of engagement and the level of engagement and involvement that we need to do with our local communities, with our local stakeholders, and with areas such as Health and Overview Scrutiny Committee and local MPs and councillors. So this is the final update following the completion of those processes. NHS England assurance made sure we went through 4 tests of service change, which was having a clear clinical evidence base, strong patient and public engagement, that we were consistent with current and prospective need for patient choice, and that we had support from the commissioning body. And following completion of all those processes, they supported us to progress. So we have obviously outlined in the paper, thanks to Shaq for pulling that together really comprehensively, about the proposals in terms of the preferred sites for relocating services will be Westbourne Green and Eccleshill Community Hospital. Westbourne Green requires a period of work to be undertaken to that, which we'll be doing, and Eccleshill has services there already, and we're also looking at what we can do within the local area to accommodate greater level of patient choice. We've outlined previously, and it's probably just important to note again, that the work and investment that would be required to bring Shipley back into use to be a modern fit for purpose site or premises, whichever you want to refer to it, is substantial and is not a viable option from a value for money perspective with where we are in the NHS. The condition survey outlined a number of areas that we would have to address, and that took us into the millions in terms of what we would need to undertake. So when we've gone through the assurance process, we've done some very robust impact assessments alongside that, and we've detailed those in the report here, but obviously Shaq and I are happy to take any questions if there are any questions on that, and we've made sure we've done the right level of engagement with communities. You'll see that attached in here we've included in detail the outcomes of the involvement report, and you can see the extent and the outcome of that. We were anticipating a number of themes that would come back, so we did mitigate that within our impact assessments, but we also provide a very detailed frequently asked questions document for people who had questions and concerns about the proposed changes to be able to run through, so that we weren't kind of going backwards and forwards with people. And we outlined the proposed mitigations that we would or we intend to put in place. It won't be a surprise to most of you to note that the biggest area of concern that has come back was access, transport, and the cost of travel. And as you've already referenced, Max, the loss of local provision in Shipley, much loved site for a number of people in our community. So we have done what we can in terms of mitigating that, and we'll continue to do what we can in terms of access to services like patient transport for people to be able to claim their travel costs back. We've provided lots of information in terms of bus routes. We'll do some more work around promoting patient choice for people, because we have lots of physiotherapy services in community-based sites, and GP practices is one example, and in other areas. So we will make sure that we have clear communication on that for people, so they know where to go. And we've heard that loud and clear in various areas of things like listening. And the feedback that's come through this. So hopefully, without kind of going through in a level of detail, because I'm conscious of the time for the board, you'll see that we have provided assurance throughout the process and in the paper. We've considered all the options that we can do. We've looked at the kind of future health provision and safeguarding it. We've taken into account people's views and their feedback. One probably particular note that came up that I haven't referenced is the covenant that was on the site. We've done all the investigation we can do, including going through all the archive service of all the old documentation. We've pulled all those files, and there is no covenant in place. If there was, it rescinded at the point that the site was handed over to the NHS at that point in time. So the next step for us following this in terms of the governance process, obviously to bring the paper here for your agreement, we have to go to scrutiny committee next Thursday for the final kind of sign off from scrutiny committee. We've had much a great level of involvement from scrutiny committee members, which has been much appreciated. And I guess the next step beyond that is working with local colleagues, whether that be the MPs, stakeholders and councillors, in terms of the future provision of that hospital site and what we do once that's closed, and the proposal that follows on from that. Shaq, do you want to add anything that I've missed specifically? I'm aware I've gone through it pretty quickly.
Thank you, Helen.
Thanks, Helen. Sorry, Max, there's nothing to add from me other than to say from a political perspective, we're at Health Overview and Scrutiny Committee next Thursday. The conversations we've had with members has been really productive, and not just productive, it was part of that conversation that helped provide us with an opportunity to have a constructive conversation with Philip Davies MP, because one of the members of Scrutiny also works in Philip Davies's office. So I think from a political perspective, so far it's gone as well as we expected to, and probably better than we expected it to.
Thank you, Shaq. That's extremely helpful. So the purpose of this, colleagues, is to notify you of the progress being made. I did disclose myself as a Shipley resident, and I don't object to the decision because it has been properly made. And I believe local people have been listened to. I'm a member of the partnership board, of course. For those of you that don't know Shipley particularly well, it's such a pity. It's a hospital it's got a church one side and a pub the other. It's beautifully and perfectly located. And of course, many local people were actually born there. They refer to it as the maternity hospital. So we do know the sensitivities here, but I do believe the decision has been properly made. There's perhaps a small clash with Access One in the sense of happy, healthy at home, because of people will have to travel a little more. But I do know from Partnership Board, for example, we're looking at ways in which we might support people that need to do that. So I'm grateful. So I hope you don't mind me giving a local informed perspective, given that I live just around the corner. But I'll bring in any thoughts or comments that people would wish to raise. That's the purpose of this briefing, of course, any opportunity to respond. Mel, would you like to come in, please?
Yes, thank you, Chair. I think we all appreciate there's nothing more emotive than closing a hospital, but I think, taking on board your comments, Chair, it may have been a hospital at some point. It has not been a hospital for many, many, many years. It was one of the first places I visited on my kind of Cook's tour, and I was quite taken aback by the amount of work that would have had and investment would have had to have been made to make good that facility. It's just beyond any sort of economic arguments. But I just want to commend Helen and Shaq and the team on an extremely well executed piece of engagement with the public. It will have impacts, and we have to try as hard as we possibly can to mitigate those impacts for those people who use those services. It's a limited number of people. It's a limited service provision by nature of the fact that the accommodation is so limited in what it could house. We are sure that the new accommodation is going to be infinitely better. So I just wanted to commend Helen and Shaq for the work they've done.
Thank you, Mel. Well said. Colleagues, was there any further comment? I think Mel, again, perhaps anticipated what I was going to do, which was Helen and Shaq, we should formally record the point that Mel makes of the thanks of our board of directors for the professional manner in which you've conducted this process, which we know can be very difficult and sensitive, as Mel herself said just then. So we wish to formally record our thanks to you for that. I think we are well briefed. We understand the reasons. The succinct briefing at board itself and the papers have helped us. So, and I can see there are no further hands raised. So we are grateful for you joining us in person, the opportunity to discuss this with you, but we're well briefed, we understand it, and we wish you every success with taking it forward now. We join you in that, of course, don't we? Is that okay, Helen? Have I missed anything you would have hoped to have heard from us?
Thank you very much, Chair. Appreciate the support of the board, and we'll keep you updated when we start to relocate the provision.
Thank you. That support's sincere. Yeah. Thank you. Shaq, Helen, thank you very much for both joining us. Yeah.
Thank you very much. See you later.
Cheers. Thank you, guys. Yeah. Okay, thank you, everybody. And yeah, kind of difficult set of circumstances, but the decision has been made properly. May I turn back to SUGRA then, please, at item 11, and just conscious that we took the maternity briefing, but we just need to just stop, pause for a moment and think through SUGRA as any matters of arise through quality and patient safety that she may just wish to emphasise with us as directors. So SUGRA, may I turn to you, please?
Sorry, Max, I thought I was covering people.
Oh, I'm sorry. It was the note you'd sent to me that I thought related to the Quality and Patient Safety Academy. You are covering people, indeed. I've got it written down twice. Yeah, sorry, the note you sent to me, I thought you meant you wanted to say something in relation to this work. So that's fine. We'll bring you in for people. So on that basis, then, given Louisa Mohammed, which I said earlier, didn't absence, was there anything that arose in the quality and patient safety update that anybody wished to emphasise or comment upon? And I suppose I should turn to Karen and Ray and just say whether is there anything QPS that you'd wish to raise with us. Now we're bringing you in then, SUGRA for people. the important subject of people. Ray, thank you.
Thanks, Max. Not going to go through the two reports in detail that Becken has read. I was just really going to mention that we've moved, as you probably know now, to splitting the Quality and Patient Safety Academy into assurance and into a learning and improvement basis. I think that's working very well. I think the timekeeping around those and being able to actually get through all the agendas is working very well as well. And as you know, Louise and Mohammed are alternating chairing those academy meetings, and I think we're actually moving to doing sort of 3 or 4 together, and then 3 or 4 for the next one. And Louise and Mohammed are writing the report for when the other one of them is actually chairing the meeting, which I think is working well as well. So I wasn't going to go through any of the detail of the papers that there is read, but I'm happy to take any questions related to them.
Thanks very much, Ray. That's absolutely fine. And Karen, any comments yourself, please?
I think it's just worth reiterating that the Lucy Letby verdict had come out just before the Academy met, and we did have an opportunity to discuss that in relation to our services as well, and we noted that it was coming to board today as well. But we talked about the fact that the neonatal unit here had been very responsive, offering psychological support to families that were on the unit at the moment, because it must have been very distressing for them to hear the Lucy Letby verdict. And we also posted some information on our website and put in writing and sent a letter to the parents who were present on the unit at that time, telling them that there were safe spaces, they could speak to people if they wished to, or if they had any concerns.
Thanks very much, Karen. Yeah, good points, actually. And of course, we don't want to make this entire board meeting about Lucy Letby, but we don't ignore it. And colleagues, directors, you've all seen the letter that came from NHS England, and I'm assured by the likes of Karen and Ray, certainly with Quality, that we will be pursuing the evidence that we are demonstrating our efforts in those areas. Do you remember it was about FTSU and appropriate data coming to board, basically, was the 5 points in that letter. So I am assured that we'll be picking up on that. Ray, Karen, thank you very much. Don't mean to rush by anything quality and patient safety, but assuming there's no further comments regarding that, we can be assured regarding the report we've got and the input we've had on maternity and neonatal. Yeah, thank you, everybody. We'll move to item 13. Sugra, I was trying to get you to run the meeting, wasn't I? So if you want to come and sit next to me here and, through the chair. So, will you bring to our attention what you wish to from the People Academy? Thank you for picking up on the chair of that at the time, Sugra. So, of course, I'll turn to Karen as well and see if there's anything she wishes to say. But I'll start with you, Sugra. Thank you.
No worries. Thanks for that, Max. Yeah, so I deputised for Karen in July. It seems a long time ago. I'll just pick out, if I may, from my report, a couple of elements that link to quality and safety, because all these things are interlinked, of course. The first one was we've heard from Sarah about the emerging concerns around our vacancy rates and our ability to deliver the mandatory training requirements against the core competency framework. At the Academy, we also talked about the difficulties that it may also present to us in terms of the midwifery continuity of care. So that was around the vacancy and the headcount and how we were going to deliver those ambitions. We also heard from one of the outstanding programmes, the theatres programme, and we were very keen to hear about elements that focus on that golden thread of sort of culture and teamwork. And we're really pleased to hear there's been a lot of interest from other teams and departments on some of the lessons learned. And then just lastly, we took significant assurance on a number of items on the dashboard, particularly given the challenging context that we've heard around the industrial action. And then just a couple of areas where we've got work in progress around the RES and DES agenda. Firstly, as we all know, around the senior leadership BAME representation. a comment really around being reflective of the local community. And then lastly, quite a bit of work to do, I think, around encouraging and empowering our colleagues to declare disability. So that's in order for us to meet the DES requirements and targets that we've set for ourselves. All in all, well attended, and we had really good input from the governors who were observing and also participating. That's all I wanted to bring up. I don't know if Fahim or Karen want to say anything else.
Super, that's extremely helpful. Thanks very much. I will turn to Karen first. May I just pick up on a small point with that? Karen, you will have a view. Is there a suggestion that we're perhaps we have a bit of a gap in terms of self-declaration of disability within the trust with colleagues there? I know Sugh was saying that disability detection rates remain low despite initiatives. So is there perhaps Sugh, do you think there's a little gap that we need to try and find a way to address?
Yeah, absolutely. So we've set ourselves a target, and we know from, I think Fahim might be a better place to answer this one in terms of percentages. But certainly, there's been initiatives around the videos involving some of our colleagues to show and create an environment where people are more likely to declare. But we spoke in the academy about perhaps making more use of some of the one-to-one conversations that take place with managers, appraisals, return to work interviews, etc. So it's very much work in progress, but it was one of the indicators where we are lagging behind where we'd like to be.
Yeah, that's great, Sugh. Thank you. Mel, I note your point. Thank you about picking up on the staff networks as well. Again, that's anticipated me on the other point, which would have been, can directors be assured that there is some action in this area to try and understand and know our working colleagues all the better. So, and I'm sure if that's the case, that's great. We'll perhaps hear from Mel there. Karen, anything you'd want to bring to directors' attention from people?
Just a couple of points. So just picking up on the disability, it's not unusual for those figures to be low across many organisations, Max. People don't like declaring necessarily that disability. So yes, it is about knowing people and understanding what kind of accessibility adjustments need to be made and other things as well. So it's not uncommon at all. And we do talk, there's a lot of work going on across the trust in terms of disability and making people feel that they can talk about these things, and KES particularly has driven that. I just really wanted to pick up on the report. It talks about the reflection on the academy effectiveness, and there were a few absences due to holidays, including my own. And the same would have happened again at the end of October, and it usually happens in March or April. And I just want to note on governance, actually, there are a lot of clashes with academies on main school holidays, which is understandable, and religious holidays as well. But what we've started to do is move the academies so that we're not short on attendees. So we've moved a couple due to Eid. And certainly the end of October, we've just asked attendees whether or not it's possible to bring it forward a week, because for some reason this October, the half term is really late, so it clashes. Now, I do think it's really important that we are flexible on that, just because otherwise you miss, your potential to miss 3 academies in any one year. And the reason it's important is because you just need that input. And the NED colleagues particularly, when we're short on NEDs, if you're chairing as a NED, and there's only one other NED in the room, it's one voice. And so I just don't think that's the way that we should be running academies. It's difficult to challenge what you're saying yourself and what you're hearing when you're chairing. You're concentrating in a different way. So I just wanted to make a note of the flexibility needed on those academy deadlines and dates.
Thank you, Karen. And I would assume directors would support you in that being with you. And we support you in doing that and being flexible, as you say, in order to achieve a greater attendance and the strongest attendance you can. Thank you. Thank you, Karen. And Sugh, thank you for completing the chair's report on this occasion and the succinct brief you gave. That was very much appreciated. Shall we move to item 14 then, please? And I will pause at the end of this, of course, and just check if there's anything arising in people that anybody would wish to check. But shall we turn to Mel to hear about the update from our Equality and Diversity Council, please?
Thank you, Chair. And largely in the interest of time and having overrun a little, what I'll do is take the report as read. I think it's a pretty accurate reflection. Apologies, it came a bit late because we only had the council last week, I think it was, or the week before. But what I want to just highlight is, and you'll see it in the spread of the pages attributed to stuff that we're doing inside the hospital and stuff that we're doing outside the hospital with partners. So it's very much a game of two halves, the EDI Council, because we're trying to capture in its broadest sense equality, diversity, inclusion and inequalities. So you will see that there's a focus in the first half really on what we're doing inside with the staff networks. And in that regard, I'm very pleased to report that for the first time in a couple of meetings, we've actually had a new chair for our Enable network. It is one of our least developed staff network. It has always been so. We acknowledge the challenges that you've just been alluding to in people wanting to come forward, but what we want to do is grow confidence in that space and all the activities. Sonia has been off for a little while, who works closely with CARES on the support of the network. She's back now, and she's raring to go alongside her new chair. And so membership, I'm afraid I don't have the most recent figures on that, but I know that it's growing. But by comparison, if you look at our resin network, we're now up to 170 people on that network. So it's got a long way to go, but I'm confident that we're right on, we're on the right track with that. Kes talks a little bit about the equality delivery system that we have to respond to. I won't go into the detail, but just to point out the sort of more outward looking issues. Of course, Carl's health inequalities presentation and some actions that we agreed to undertake as a consequence of that. It was a great discussion about it. Partners from Actors One came and talked about our relationship with the Actors One space in tackling health inequalities. And then the final external speaker was Zara Niazi, who is the wellbeing for Bradford District and Craven EDI lead. So we got to learn about the work that we are very much a part of, but is being led from a place perspective by Zara, working very, very closely with CARES as the health and care EDI lead for Bradford District and Craven. Happy to take any questions, Chair.
Thank you very much, Mel, and thank you for what's being done there. It's clearly been commended a couple of times during the course of the meeting. Does anybody have any questions for Mel regarding the work on the equality and diversity and inclusion and was there another E? No, I was trying to remember.
Equality, diversity, inclusion, and we've wrapped up inequalities in the sort of I bit. Yeah, there's two aspects to that.
Thank you very much. Okay, if there are no questions arising, we're helped by the very useful report and Mel's briefing. That's great. We can move on. Thank you very much, everybody. Shall we move to item 15 then, please? And again, stay with Mel for anything Mel would wish to bring to our attention regarding partnership work. So, Mel, with you at item 15, please.
Thank you, Chair. Happy to take questions. Happy to take the report as read. It's a familiar format against which we are, and I think you've heard throughout the meeting, very much contributing to working in good partnership and collaboration across Bradford District and Craven.
So again, an attempt at providing a single view to directors of the work that's being done there, and we shouldn't avoid that, of course, but we do discuss partnerships during the course of our general matters, don't we? And I think the example with Chris Smith for the financial pressures and then the nature of our partnerships challenges there, I think was really a good example of us thinking beyond the walls of the trust. So that's good. Partnerships dashboard, anything anybody would wish to raise? It's all very well attended. You know that it's well supported by the trust with myself and Mel and with Cameron and Julie in particular. But of course, I do know that exec directors have specific roles as well within partners. So, okay, if there's nothing further, that's great. We'll move on to the audit and assurance section. We'll just take 1 one or two items here, and then I'll just stop for another short break, if I may. But I think what I'd like to do is get into taking the report from the chair of the audit committee and then the ask of the board in relation to being assured by the annual report and approving the minor amendments to the terms of reference. So let's deal with those two things now, and then we'll just take a short break again and give people a chance to stretch their legs and get a cup of tea and keep going. Okay, so moving to item 17, Barry, can I bring you in, please, and invite you to bring to our attention what you would wish from your report, please.
Thanks, Max. Yes, this is a report based on the key points covered in last week's audit committee meeting. I think it's, well, I'll find out in a moment, but I think it stands on its own. It's there to be read, but I'd be happy to handle any comments or questions that people may have.
Thanks very much, Barry. I would always want to give you an opportunity if there was anything particularly you want to emphasise. But if you feel that having read the board, directors are well briefed as to what's on the mind of the committee at the moment, and that's great. Colleagues, may I ask whether anybody requires any further detail, or are you content to note the report, please? And I will assume from that you are happy to note and derive assurance from Barry's very full report, extremely helpful and current, of course. So, colleagues, comfortable with that? That's great. Well, shall we stay with Barry then, please, to bring to our attention the annual report itself and anything he would wish to emphasise with us there, and an ask of the board for approval of the minor amendments to the terms of reference of our audit committee. So again, with you, Barry, as you see fit.
Yeah, well, first of all, the annual report, it summarises the activities of the audit committee during the period from July 22 to June 23. In essence, its purpose is to confirm to the board that the committee has complied with its terms of reference, which the report does. My thanks to Jackie, who drafted this report. It's not an easy job to do, to go back over the year and summarise things, but happy to take this also as read, but happy to answer any questions or deal with any comments that fellow board members may have.
I must say I found that very useful reading, Barry. A great description of the things we need to think about with the annual report. So it was terrific. Thank you.
Okay.
Yeah, very well.
If I move on to the terms of reference, it's that time of year again where we carry out our annual review of the audit committee's terms of reference. We've done that. You'll have seen the minor amendments in track changes that are proposed, and the audit committee in its meeting last week undertook to recommend to the board that it approve the changes and approve the new version of the terms of reference. I think one thing to point out, a good reference source for the audit committee is a document published by the HFMA, which is called an audit committee handbook. A new version of that handbook is due for publication in, quote, late autumn. And the reason for the new edition is primarily to respond to the requirements and stipulations of the Health and Care Act 2022. So we're asking here for the board to approve the minor amendments to the terms of reference, but bearing in mind that there will probably be further changes, amendments and improvements required when we have sight of this new handbook, hopefully before the end of the year.
That's very helpful, Barry. Thank you. Thanks for that context there. So, colleagues at board, we're just being asked to approve, please, the proposed amendments to the audit committee terms of reference. Is there anything anybody would wish to ask for clarification on, or are you comfortable with the amendments, which are helpfully sketched out for us, aren't they? It's easy for us to note what those amendments are. I think we unanimously approve. So thank you, Barry. Thank you for your leadership in that area, Barry. And as of course we move, Barry, towards looking at a new chair, of our audit committee, actually a couple of governors asked whether they might just hear from you and have a quick word with you about what you would consider the ideal skills of an audit chair. And so I realise I'm mentioning this open board, but I'll drop you a quick email, Barry, with the two. It's entirely appropriate. There will be members of the interview panel there, and it was good on them that they wanted to know from perhaps yourself what you would consider the ideal skills to be looking for. So hopefully you'll do that, please. Yeah, great stuff, Barry. Yeah, I'll drop you an email later today, and that'll be smashing. Thank you very much. Yeah, thank you, Barry. And if people are content there's unanimous approval there for the terms of reference minor amendments, and we do note the annual report and take assurance from that. May I suggest that we just take item 19 and then we will break, okay? So, because we're doing reasonably well getting through these matters that just require our brief attention in order to approve. So let's just take a moment, given how much Laura has got, of course, in section 5, and there's matters for approval in there. So we just give Laura the chance of a break as well. So shall we turn to our board assurance framework and high-level risks, and invite Laura to bring to our attention those matters that, or if anything, of course, that she would wish to emphasise in addition to reading the reports themselves. So with you, Laura, please.
Thank you, Max. So I'll start with the board assurance framework, and then I'll pause and then before moving on to the high-level risks. Perfect. So the board assurance framework sets out our strategic risks to achieving our objectives, and it's reviewed every 2 months. It's reviewed by the lead directors for each of the risks. It's then looked at through the executive team meeting and through the academies. Because we didn't have finance and performance and people academies at the end of August, it was sent to them by email, but we didn't actually receive any comments back. There are 2 risks which have reduced in score this time. So 2B.1 around the transformation of services, that's reduced from a 16 to a 12 due to the progress that's being made there. And risk 4.1, which relates to the learning experience for trainees, that's reduced from a 12 to a 9. Following some sort of more positive GMC survey results this year. I think that's everything I wanted to highlight in relation to the BAP, so I'll just pause in case there's any questions on that.
Thank you very much, Laura. So again, colleagues, was there anything within that board assurance framework that anybody would like to raise for further discussion or clarification, or indeed any matters that colleagues might not think properly represent just where we are? Are we content to note that? I think we are. Thank you, everybody. So, Laura, we'll move to the important matters of high-level risks, please.
Thank you. Yeah, so just moving on to the high-level risk register. So these are our operational risks, scoring 15 and above, and these are reviewed on a monthly basis through the executive team and the academies, and obviously here at the board every 2 months, every time we meet. So last time the risks were reviewed, I think we just had one which had passed the target mitigation day, and that was risk 3800 around an increase in the cost of gas and power. So that mitigation day is just going to be reviewed and updated. We had 2 new risks accepted onto the register. So 3881 relating to unfilled pharmacy vacancies and the impact on medicines reconciliation rates. And 3885 around operational security, supervision, management and resilience. In relation to the security risk, it was agreed that the description needed to be reworded slightly, just to confirm that that's relating to a lack of 24/7 supervision of the operational security team. So that risk description has been amended slightly now. There were 3 risks that were overdue for review. I think 2 of the 3 have now been reviewed, and the other one will be reviewed as soon as possible. And finally, just to note that in June, the executive team did have noted that there were quite a lot of risks on the register that had been there for a long time, and there were some where there had been quite a lot of changes to the mitigation dates. So in August, we did have a bit of a deep dive session on those particular risks. I mean, that did show that the risks that were on there were still relevant and appropriate, which I think is positive. But yeah, just to give the board that additional assurance that the executive team has done that more in-depth review. the ongoing risks.
That's helpful, Laura. Thank you very much. Yeah, and they're all laid out for us there with the updates that Laura's brought to our attention, the ones that are just behind a little, and some amendments that have been made in recent times. Were there any questions or queries or thoughts that might have arisen in relation to these risks? Karen, please.
Thanks. I think it's just worth spending a couple of minutes on this. So the additions to the risk register, so we've got the security risk and the pharmacy risk. The security risk is currently under review because we need to understand what that is and what mitigations are in place. And Saj now babysitting and being the exec lead for all things E&F will be looking into that. The second one is around the pharmacy risk, and throughout our discussions, whether it be a moving to outstanding, where we look at the CQC, or the discussions that we have at board or academies, we realised there wasn't a risk in relation to pharmacy, and it sounded like it was an area of high risk considering some of the discussions that we're having. So that risk has now been articulated. We know there's staffing concerns in that area, but the knock-on effect of that is the medicines reconciliation, the risks with that, the percentage compliance of that. And it just gives a little bit more oversight, I think, of those tangible things that we need to be keeping an eye on. So really welcome that risk onto the risk register. The final bit on existing risks, so Laura's right. We did sort of say, well, let's hold a mirror up to ourselves and then have a look at some of these risks that have been on for an awful long time. And what you find is that things like staffing or things like the finance risks come and go and up and down throughout the year. So they're always there in the background, but the scores change. It doesn't mean that we're not handling those risks properly. It means that they change. But it did give us the opportunity to say, does some need to be closed? Does the risk assessment need redoing? Did they need rewording? I do want to pay attention though to the staffing risk. So People Academy has a particular interest in staffing and all things nurse staffing, and we've received a number of reports now, and in fact I'm just going through the reports for this month's meeting where we're looking at our recruitment and retention plans for nursing and midwifery. It is and has remained a challenge, and a significant challenge for the last 18 months, if not longer. There are clear plans in place, which is around overseas recruitment and our own internal recruitment, but a bit like we were talking about the impacts of strike, things are safe. Are we giving people the best possible experience all of the time? Probably not, because we know that we're running with vacancy rates that we don't want to be running with. So it's just to give some further assurance that there are robust plans to address that and to move towards a place of improved recruitment within nursing and midwifery, and that the People Academy are well cited on that. Thank you
very much. Yeah, quite right, Karen, and for you to actually just pause and remind us of the articulated risks in pharmacy, aseptic, dispensary, etc., and of course the work that's being done there in the outstanding programme. You're quite right to just remind us and emphasise the work that's ongoing in that. Thank you, colleagues. We know Karen's point, of course, that the risk register represents work that's ongoing, and we are trying to get on with mitigating those risks. Is there anything in terms of detail or further information that's required? Are we content to note the work there and to endorse the register as a fair reflection of where we think our risks are? I mean, a good example of that, didn't we? A recent board meeting on board development where we added on, didn't we? So that's good. Okay. If there's nothing further to add, I will take that as noted and assume that there is full assurance there from what we've got. Thank you, everybody. So we're going to finish the board meeting by the matters of governance. What we got? 1, 2, 3, 6 items there. Some are only to note, but there are a couple of matters that require our consideration and approval. When I say only to note, of course, it invites questions, etc. I've got it's 1:20. Shall we just take 15 minutes? Shall we do to 13:35 to let people get a leg stretch, grab what they have to, go and run and get a sandwich if they need to, and we can start again at 13:35 on this computer. Yeah, so 15 minutes.